Hello and welcome. I am Kim Nitz, a Community Program Manager for the Parkinson's Foundation. We are passionate about helping every person with Parkinson's to live better, so it's great to be reaching so many of you today in our virtual meeting format. We have participants from all over the state of Texas, as well as Oklahoma, Arkansas, and beyond. We welcome you all. Today's program is in collaboration with expert presenters from the greater Texas area, and we truly thank them for their passion around community education. The Parkinson's Foundation is here to support the 1 million Americans living with Parkinson's disease, as well as the many who care for them and those working to end this disease. For those of you new to the foundation, we focus on 3 pillars: advancing Parkinson's research, improving care for those living with Parkinson's, and empowering the Parkinson's community with educational resources. These resources are extensive and include our website, parkinson.org, our free educational book series that you can download or order in hard copy, a library of recorded podcasts and webinars, and our hospital safety kit called the Aware and Care Kit, which Marcie will discuss later on in our program. And a great resource, if you have not connected with them yet, is our national helpline at 1-800-4PD-INFO, which is staffed with Parkinson's specialists ready to assist. Additionally, we have a set of newly diagnosed resources, which is a great starting point for those who've recently begun their journey with Parkinson's. You can contact our helpline for further information. Across the country, the Parkinson's Foundation brings the community together through Moving Day, A Walk for Parkinson's, a national fundraiser to support Parkinson's research and local wellness programs. On March 27th, we will host a virtual Moving Day San Antonio and welcome all of you to get your team started now. We are also proud to offer PD Generation, a national research initiative that provides genetic testing for PD-related genes and genetic counseling to people with Parkinson's at no cost in English and Spanish. The goal of PD Gene is to leverage genetics as a powerful tool to help us uncover what is responsible for slowing or stopping the progression of Parkinson's. Learn more and enroll at parkinson.org/PDGeneration or call our helpline. As we all continue learning and engaging from home, we are offering a series of online programs each and every week that includes Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. We have some great programs coming up on topics like art, music, and caregiving. So we hope to see you at one soon by signing up at parkinson.org/PD Health. And PD Health at Home is presented by the Light of Day Foundation, whose generosity has made that programming possible. Now, before we get started with our first speaker, I just want to thank the silver sponsors of today's program: Lundbeck, Adamas, UCB, and Kiowa Kirin, as well as our exhibitor sponsors, Boston Scientific, AbbVie, Synovian, and Amneal. Their support helps keep today's program and many others free and available to our PD community. You can find educational materials about these companies and their educational resources by visiting our virtual exhibit hall located at the link you see on your screen and in the chat. And now we are ready to hear from our distinguished set of speakers. In your confirmation email for today's program, you'll find a link to their full biographies so you can learn more about each speaker. And first, I am pleased to welcome Dr. Nirav Pavasia, a movement disorder specialist from Neurology Consultants of Dallas. I'll remind our audience, please submit your questions at any time via the Q&A icon. And I will now turn it over to Dr. Pavasia.
Yes, hi there, everybody. Thank you for joining in. I hope everybody can hear me there. And so basically today, we're gonna be talking about Parkinson's disease. There's a lot to learn, okay? And I'm going to share my screen here so we can get it going. Okay. All right. Okay, perfect. All right. So again, thank you everybody for joining in. Today we're going to talk about Parkinson's disease, especially the middle stage of the Parkinson's disease. And I currently practice in, neurology at Neurology Consultants of Dallas in Dallas, Texas. I'm one of the movement disorder specialists. So today's objectives, I'm gonna go in a little bit of a historical perspective of Parkinson's disease, and we'll talk about some just general information of Parkinson's, and then really kind of focus into the middle stage of the disease, where we'll dive deep into the options of how to take care of this stage of the disease. So a little historical perspective. Essentially, the first time Parkinson was described was back in 1817 by James Parkinson. He described the symptoms of Parkinson in an essay called Shaking Palsy. That was back in 1817. So we just celebrated a little over 200 years of anniversary there. And then for longest time, after he recognized this disease and it was named after him in 1872, and again, long after that, we did not have any medication options or anything, to treat the symptoms of Parkinson's until late, early 60s to late 60s. That's when the levodopa therapy, was invented. Initially, they were given levodopa therapy through IV. Patients would have lots of nausea, vomiting. Because of that, even with just oral levodopa, they were having a lot of that. And so slowly they found out that carbidopa in the gut can block the activation of the levodopa. And so that was added. And so the nausea was substantially less. Over time, new medication options emerged, but not until late 90s. Really, and then last 2 decades there have been a lot more medication options that we'll talk about. But essentially, levodopa therapy is still a gold standard therapy that we still use to this date in treating Parkinson's disease. So who gets Parkinson's? Estimated about 1 million people in the United States have Parkinson's disease. I think the number is still kind of underestimated. I think the number is probably higher. About 10 million or more people worldwide are affected, and our estimate is that about 60,000 new cases are diagnosed every year. So this is a very growing disease. It's the second most common neurodegenerative disease after Alzheimer's. It can affect anybody, regardless of their race, ethnicity, or gender. And most patients or most people are diagnosed when they're in their older age, between 55 to 60. Now, I don't consider that to be that old, but 55 to 60 is the typical age of onset. But there are a small subset of patients, maybe about 5 to 10%, small number, have a young onset Parkinson's disease where their age is anywhere from in their 30s or 40s and such. What causes it? Now, we don't have an idea, or the reasons of developing Parkinson's unknown still, but scientists believe that it's a combination of genetic and environmental factors that may contribute to increased risk. In this picture, you see a man with the pesticide or herbicides there. That's one of the risk factors. The other risk factors include, well water drinking, living in a rural area, etc. Genetic factors may also play a role. About 10 to 15% of Parkinson cases are inherited and from maybe gene mutation. Now, that area is also big in research right now. We're finding more and more gene mutations that may cause the disease. So the cause is still largely unknown, but we are trying to find, through research, what leads to this disease. Older age, traumatic brain injury, other risk factors that may cause Parkinson-like symptoms, or that may lead to Parkinson's disease. So what is happening in the brain? What leads to this symptom? So we all have this dopamine neurochemical. They're produced by in part of the brain called substantia nigra, and these neurons synthesize dopamine, and then that then travels upwards into what we call, there's a structure called basal ganglia, and that's where the dopamine signaling pathway is. So if your body tells your arms and legs to move, this dopamine gets released and signals that pathway for movement. And then you end up moving. So dopamine is important for not only for movement, but there are other things that it's helpful for, such as mood, cognition, sleep, speech articulation. So coordination of movement, these are all other important functions of dopamine. And so we are currently working on how to stop or slow down the loss of dopamine producing cells. So what happens in Parkinson patients, that these dopamine producing neurons, they start to die off much faster rate than the aging process. And that's the unknown reasons why. We don't know why that happens, okay? There are other neurotransmitters are at play that's involved in Parkinson's, such as norepinephrine, serotonin, glutamate, acetylcholine. These are all other neurotransmitters that may play a role in causing other symptoms of Parkinson's, just other than the movement. All right. So what you should know about the symptoms. So it may affect your, for the longest time we thought that the Parkinson only affects the brain, and slowly over time, at least in the past 2 to 3 decades, we have learned to realize that it affects most of your body, in their, arms, legs, so, as well as the GI system, your skin, your heart, conduction system. I mean, it affects all varieties of organs. But largely, Parkinson's is known as a movement disorder because of the tremors and slowness in movements and stiffness of the muscle and joints that it causes. So for the most part, we think that this is a movement-related disorders, okay? But there are a lot of other symptoms that it can cause, and we'll go into detail about that later. So, and these symptoms vary from person to person and usually develop slowly over time, as well as also it's a slowly, chronically progressive illness. And so the neurologist who treats this disease mainly is a movement disorder specialist because, that's a subspecialty of neurology. So basically, you want to establish care with the neurologist, when you're diagnosed. So how is it diagnosed? So there's no one particular way to diagnose Parkinson. However, it can be made, the diagnosis is made through clinical exam and medical history. So largely, we still don't have a blood test or, or any kind of other procedure that can lead to the diagnosis. So neurologists may look into your history of symptoms, when they started, what side of the body it started, and how the progression has been, So after taking the history, the neurologist may conduct a full exam, especially a movement-related exam, what we call, there is a scale for it called Unified Parkinson's Disease Rating Scale, or UPDRS, that can help to diagnose and to monitor symptoms. And one way to do it is, which as a movement specialist, I, usually don't recommend, but is check the response to Parkinson medications, So historically, a primary care physician may say, hey, you may have symptoms of Parkinson's disease. Why don't you take this medication, see if it improves? And if if improves your symptoms, then you may have Parkinson's. Okay, so that's one older way of, kind of diagnosing Parkinson. Then there is this scan called DAT scan. It's a nuclear PET imaging of the brain. Basically, it's a scan that checks the dopamine activity in the brain. It's usually not necessary. We don't do it on every patient if we feel high, confidence in a diagnosis. But it can be done in certain situations to help aid in the diagnosis. especially when patients have different types of tremors, they're overlapping, or they are on some other medication they're taking that may cause Parkinson-like symptoms. That's when we typically pursue the DAT scan imaging. So now let's focus our attention to the middle or mid stage of the Parkinson disease, and we have a lot of ground to cover. A lot of learning points here. So these are the main points that I would like to go over today in my presentation. So typical progression of Parkinson disease, I'll talk about each stage, and then we'll talk about what are the motor fluctuations that can happen and when it can happen. And then current medication options to treat your movement-related symptoms. Then we'll talk about the medications for motor fluctuations, procedural options, and then non-motor symptoms, which are non-movement-related symptoms, and then the importance of exercise and rehabilitative services. So first, we'll talk about the, how the Parkinson disease starts and progresses. So this diagram is quite busy, but I'll kind of, go through left to right. So on this side, the up arrow, this is just a degree of disability a patient may get. And on this dark, blue line here is, timeline in years. So, initially onset of non-motor symptoms can start. We call this a prodromal stage, which is patients may get constipation, loss of sense of smell, or fighting or enacting their dreams at night while they're sleeping. So these non-motor prodromal symptoms can happen. It can happen 5, 10, maybe up to 15 years prior to their movement-related symptoms. Okay, so then comes the next set of symptoms, which is the onset of motor symptoms, which is that tremor, stiffness, slowness, shuffling gait, stoop posture, handwriting getting smaller, etc. And that kind of goes into the early stage, slowly it progresses over time where, the diagnosis may be made from the onset of symptoms, maybe even down to 3 up to 5 years later, because, sometimes the patients don't think the symptoms are bothering them until it gets to the, bothersome level, and then they seek medical attention. So the diagnosis is made, and then patients may start their Parkinson medication. So early stage is quite beneficial with the medication. We call that a honeymoon phase also, because patients respond to medication quite well. Then comes the mid stage, and this is the stage we'll talk about for the rest of the presentation, where the medications are still responding, but now you start having these fluctuations of the responses. Okay, you may not have the ideal control of your symptoms, and you may feel like the medications are failing. And on top of that, the dyskinesia starts to happen. And I will kind of go over these terms. Dyskinesia basically is just extra, excess movements, involuntary movements. So that can start to happen in the mid stage, and it can progress into the late stage, these fluctuations and dyskinesia. And then the late stage, you start having a lot of the non-motor related symptoms where, patients start having, memory cognitive decline, hallucinations can happen. They may have lightheadedness, dizziness, urinary symptoms. They may have movement-related complications such as gait problems, falling, all these things start to happen in the late or advanced stage of the disease. And so, the bottom part of the graph here says when to find out about the DBS, which is the surgical option. We'll go into detail again, but the mid stage is the ideal stage where you want to address it with any kind of surgical option. Okay. All right. So let's talk about motor fluctuations. So what are some of the terms you need to know as a patient and a caregiver? So there's a term called on time. Basically, what that means is the levodopa therapy or any dopamine medications are in effect, and you have good control of your tremor, stiffness, slowness, or movement-related symptoms. Okay. So basically, you're able to carry out your activity well, and you're able to function well that's what we call it on time. Off time is when the levodopa or other medications are in effect or are wearing off, meaning the effect of the medication may be wearing off, and the symptom control is poor. So the symptom starts to come back, the tremor, stiffness, slowness, and your ability to carry out daily activities become difficult, such as walking or getting up in and out of chair or bed. And so that's considered, your off time. And this can lead to worsening of motor or non-motor symptoms, which is, some patients may feel, as the medication is wearing off, they may feel slow cognitively, they may have slurred speech, they may feel confusion, they may have anxiety attacks. These are some of the other symptoms that can happen during off. Then there's another term called dyskinesia, which is dys meaning abnormal, kinesia meaning movement. So abnormal excess movements, okay? So when levodopa or other medications are at its high levels in the body, your body responds with too much movements. These are involuntary fidgetiness, writhing, dance-like movements, jerking, flailing, and it can occur throughout the body. And these can lead to quite a bit of bothersome lifestyle where you have social stigma about it, inability to carry out your daily activities, can lead to imbalance or even falling. So this symptom can be quite troublesome. Dystonia, dys meaning abnormal, tonia meaning tone. So this is a muscle group that are continuously contracting, again, involuntarily, and this leads to abnormal posturing or twisting of your part of your body. And basically, these symptoms can be part of your off period or can occur at any time. Dystonia leads to muscle stiffness, tightness, and can be painful, can cause difficulty with walking or even falling, okay? Freezing can happen. So freezing is an inability to move with one or more legs due to being stuck or glued to the floor. So your brain tells your body to move, your brain tells your legs to move, but they're just stuck to the ground, okay? So we call that freezing. Freezing of gait can occur during mid to advanced age and leads to significant disability due to inability to walk, and it's a high risk for falling, okay? Typically can occur during off time, or it can occur at any time as the disease advances. So this can lead to, this is especially more common freezing when you're going through narrow areas of the doorways, or when you're changing texture in the flooring. So if you go from carpeted floor to a tile floor, that's when you will get the freezing. Or if you're going from wooden floor to different pattern of the tile floor, that can cause freezing. So it seems like more, brain trick, if you will. So those are the motor fluctuation symptoms. So how does that look like in your typical day of, Parkinson's disease? So as we talked about the early stage here on the left side of the graph here, the early stage, if you see the top part of the graph, it says on with dyskinesia, the middle of it says on, and then the last part is off. And then you take the levodopa early morning, you feel good on time, and the medication's working well, and then it wears off, you take another dose, and then, you feel on, and then, wears off. So it's a kind of roller coaster ride, if you will, correct? So, where you feel your symptoms are pretty well controlled throughout the day, and this is your early stage of the disease. Now, fast forward to the mid stage of the disease, you're spending more time in your off state, and some of the time or more time in the dyskinesia state. And there is less and less time in the on stage, okay? And your requirement to take levodopa therapy is also quite high. So this can start to happen in a mid stage where you have less control of your symptoms. You're either moving too much or moving too less. And that's the roller coaster ride that you kind of go through in the middle stage of the disease. So why do these motor fluctuations occur? Again, no scientific reason has been determined at this time why they occur. There's considerable amount of controversy whether they happen because of the disease duration severity, or is it because of the treatment with the dopaminergic therapy. Okay, so we don't know which one is causing it. In my opinion, I think both contributes, okay? There are some observational studies that have shown that motor fluctuations are more common in the young onset Parkinson patients with longer disease duration and increased disease severity. So patients who have a longer, duration of the disease. So if they've had it for 3, 5, or 7 to 10 years, they're at higher risk of developing fluctuation, young onset patients as well. And other factors that may play a role is this pulsatile dosing of levodopa therapy. You do that day in and day out, and that kind of changes the architecture of the brain. The brain adapts to different pulsatile dosing of this medication. And also the higher doses of the dopaminergic medication may contribute to the motor fluctuations. But, again, these are all theories. We don't have a, pinpointing answer. So how do you determine if you have motor fluctuations? So the best thing to do, and I advise this to a lot of my patients in the clinic, that you create a symptom diary for about 1 or 2 weeks, sometimes even longer. And that's by far the most important step you will take, whether you're having this off periods, dyskinesia periods, dystonia, or freezing of gait, okay? The symptom diary will help you to know what symptoms you're having. You will know your body, disease, and medication response. It's actually a very good learning experience for both the patient and caregiver. You will understand your disease better and how to tackle it better. And while you're doing this diary, it's important to document whether your symptoms are troubling you or do they interfere with your activity of daily living or not. So you just don't want to document the symptom, but you also want to document whether these affect your day-to-day life, okay? So it can, and then once you bring that diary to your neurologist or movement specialist, then they can create a better methodical treatment plan for you. So I recommend to create this diary for all stages of Parkinson's disease. So why do we need to treat motor fluctuation? Why do we need to take care of this? So it's basically the impact that motor fluctuation causes to patients and caregivers. So patients can have increased gait difficulty, high frequency of falls, and hospitalizations. Patients may feel hopeless, depressed. They may start to live with the symptoms of the off episode dyskinesia. And they may say, hey, I guess this is just me. This is just part of my Parkinson's. And even though your quality of life is poor, you just say, okay, I'm just going to go with this. Then over time, patients may become more withdrawn, interact less socially or with other family members. And these symptoms can cause dependence on the caregiver, which then raises a caregiver burden. Then the relationship suffers between the patient and caregiver. So overall, it has much detrimental down the road effect that leads to poor quality of life for the patient and the caregiver both. The goal in treating the motor fluctuation, the goal is that we want to keep you physically, mentally active and independent as long as possible and have a good quality of life. So let's say if I have a patient who comes in at age 70 or let's say 75, and they're having these symptoms, and I say, hey, let's do something about it. And they may say, why do we need to do something about it? I'm okay. But, clearly they were having, poor quality of life. And I say, well, you have, let's say if you're going to live up to be 100 and you have 20 to 25 more years to live, it's better to live those years with better quality of life. Okay. You don't want to just continue on living with the symptoms if there's something we can do about it. But now if these symptoms sometimes, if they don't bother you at all and you're pretty stable otherwise, I have some patients say, I'd rather move a little extra than not move at all, those type of things. Then I say, okay, well, let's just wait and watch. We may not have to change anything. So how do we treat motor fluctuations? So neurologists or movement specialists may do one or more of the following to treat the motor fluctuations. We may increase the dose of frequency of your medication or change the medication to other extended release formulations or other class that may prolong the half-life of the levodopa or may add other rescue medication options. These are on-demand or as-needed medications. Lastly, but importantly, we may even suggest advanced therapy options such as surgical procedure, DBS, or Duopa therapy. And we'll talk about all these options in next covering slides. And there it is. So let's talk about what are the current medications available to treat the motor symptoms, which is the tremor, stiffness, slowness. Okay, so this is a good list of medication. The first, on the left side, the providing supplementing dopamine. So Sinemet, or carbidopa levodopa, we call it. You take it, it gets absorbed through the intestine, and the levodopa then reaches to the brain and gets converted to dopamine, and then it does its action and then wears off. So it's almost like supplementing with dopamine. Okay, so Sinemet, Rytary, Inbrija, these are all levodopa class of medications. Then you can have a mimicking of dopamine action, which is what we call dopamine agonist class. And you may be aware of these: pramipexole, ropinirole, rotigotine patch, which is a Nupro patch we'll talk about, the subcutaneous injection, epimorphine, and as well as the sublingual film. Then you can make the levodopa last longer. Okay, so some of the medication that prevent breakdown of dopamine, which is rasagiline, sulfinamide, entacapone, opicapone, or Stalevo, which is a combination of entacapone and carbidopa levodopa. And there are others which don't fall into those dopamine class categories. So istradafylline, which is Noriance, amantadine, extended release, or trihexyphenidyl. Okay. So let's go over now what medication we use to treat the motor fluctuations, okay? So some of the extended release medication, which is Rytary, Nupro, or rotigotine patch, opicapone, these are amantadine extended release. These are the extended release mechanisms. Then there is a continuous delivery of the carbidopa levodopa, which is the Duopa pump we'll talk about. Then rescue options, Inbrija, Epican, Kinmobi, and lastly, Norian. So let's go over each one of them in a little bit of a detail. So Rytary, which is a true carbidopa levodopa extended release capsules. Okay, these are capsules, and inside each capsule there are immediate release beads and then extended release beads. Okay, so it was first FDA approved in 2015. These are contains the beads of immediate and extended release of the medication, and the medication effect can last up to 4 to 6 hours. So compared to that, regular carbidopa levodopa may last close to 4 hours. This may extend by another hour or two, maybe up to 6 hours, okay? Now, the next one is Nupro, or rotigotine patch. So this is a patch form of medication. It was FDA approved in 2012. It's a 24-hour patch. So you change this patch on daily basis, especially when, before and after shower. It's a continuous release medication that absorbs through skin. And it can be applied through like upper arm, upper leg, abdominal area, upper back, or lower back, okay? So this can also help kind of give you smooth dopamine activity in the brain. Then comes the opicapone. This was one of the medications that was approved in 2020. While the pandemic is going on, it was to be used with carbidopa levodopa formulation. So you cannot use this medication by itself. It's an adjunct with use of carbidopa levodopa, and it's taken at night, once at night on an empty stomach. It basically boosts levodopa effect and makes it last longer. And helps with the off periods, okay? The next one is Gocovri, or amantadine extended release. This was FDA approved in 2017. It's the only medication approved by FDA to treat dyskinesia as well as the off episodes. It's 2 capsules taken at night at bedtime, okay? Then comes some of the rescue medications. So rescue medication options are great when you have wearing off effect of the carbidopa levodopa. Let's say your regimen is taking it every 4 hours, but your carbidopa levodopa wears off within 3 hours, and you don't have, it's not time for you to take your next dose yet. So you have an hour to kill. So then you may feel slow, stiff, or have tremor during that time. So how do you, troubleshoot that time? So levodopa inhaler, which was FDA approved in 2018, you can do this inhaler during that time and can buy you up to an hour or so, where you can continue to have good control of your symptoms. So it's a different way of delivery. It gets absorbed through your lung and directly into the bloodstream. So it bypasses the GI system, which is great. So it acts pretty rapidly. It can last up to an hour. You can use it as needed up to 5 times per day. So it helps with off episodes, and it buys time between doses of oral carbidopa levodopa. Some patients use this even early morning where they feel they took their carbidopa levodopa and takes them an hour or two to kind of start going, okay? The next one is Kinmobi, or epimorphine sublingual film. So this was the second one that was approved in 2020 during pandemic. It's a delivery via sublingual film for rapid release of the epimorphine medication. It's a dopamine agonist class. It's absorbed through mouth and directly into the bloodstream, bypassing the GI system. Again, short lasting, hour to hour and a half, and you can use it up to 5 times per day. And it helps with the off episodes and buys time between doses of oral carbidopa levodopa. Another rescue option. This is a rather old medication approved in 2004. It's a subcutaneous type of injection, a very tiny little needle, about an inch long. It's you just use it subcutaneously. You're not going into the muscle. It's not too painful. Just feels like a little pinprick type of thing. But it absorbs really fast. The medication can last 1 to 1.5 hours. Again, you can use it up to 5 times per day, and it helps with the off episodes and buy times between the doses of oral carbidopa levodopa. This is, again, a rather new medication, FDA approved in 2019, istradafylline. This medication was in use in Japan for a long time. And then FDA, we got final approval in 2019. It's a non-dopaminergic class, and it has unique mechanism of action in the brain. It's an adjunct medication to use with carbidopa levodopa. It's taken once daily. And again, it helps improve wearing off symptom. Okay, it comes in 2 doses, 20 and 40 milligrams. So these are medication options that can help, treat the symptoms. Now let's look at some procedural options of the motor fluctuation. So we'll go into a little bit of detail about the deep brain stimulation. So there are 3 companies now that make the DBS device or deep brain stimulation devices. Medtronic, by far the oldest company. Abbott came in about, I would say, 5-6 years ago, or I would say 4 or 5 years ago. Boston Scientific just 2+ years ago or so. So they have made quite a bit of technological advancement in the deep brain stimulation, the way we provide therapy. And so what is it? It's a type of brain surgery where a very thin type of wire kind of is implanted deep into the brain. That's why it's called deep brain stimulation. That delivers very small voltage current in parts of the brain through the battery. So it's like a pacemaker type device, as you can see in this picture. So it's kind of like a pacemaker for the brain. You have a pacemaker for the heart, this kind of similar concept. And it can help improve Parkinson's symptoms such as tremor, stiffness, slowness, and those motor fluctuations, the wearing off and dyskinesia, dystonia, all of those symptoms. So it's quite helpful if you get it done in the right time. So I'm going to kind of quickly go over some of the frequently asked questions we have. These are the similar question I get asked in the clinic. So I've just kind of put that in the presentation here. So who can qualify for deep brain stimulation? So you should have a good response to carbidopa levodopa. That's a general rule of thumb, but some patients don't have response to carbidopa levodopa, and they still can be good candidate. But general rule of thumb is that we want you to have some response to the carbidopa levodopa. If you have motor fluctuation, then you're a good candidate. And if you don't have a significant memory cognitive impairment, okay? So if patients are in their advanced stage, and if they're having a lot of memory cognitive decline, or they're falling all the time, etc., they're not a candidate, okay? So those patients, we have to look at each patient individually and see, and we have to be realistic what we are treating. So what does it help with? It helps with the tremor, stiffness, slowness, and those motor fluctuations, the off periods, and dyskinesia, dystonia, etc. And what does it not help with? So if you have a lot of imbalance of gait, freezing of gait, or falling, it doesn't help with too much with that. If you have memory cognitive impairment or other non-movement related symptoms such as constipation, urinary symptom, dizziness, depression, anxiety, hallucination, delusion, or that fighting behavior at night when you are sleeping, these non-movement related symptoms, the DBS will not help with, okay? So when should one get this done? My answer is the earlier the better. There's no recommended age cutoff, but better outcomes are achieved if you do it while your memory cognition is relatively preserved. But case by case approval is usually done. I do have, a few set of patients who are in their early 80s, but they're so much physically fit, mentally fit, very active. And, we have gotten it done for them and they're still doing great, okay? But there is a data that suggests that patients who do this procedure in their mid or early stage of the disease, the motor symptoms are quite better controlled. Patients have better quality of life and have satisfactory outcomes when compared to doing it in an advanced stage. And that's a typical misconception. A lot of patients say, hey, I'm not bad enough yet, or I'm not in advanced stage yet to get this done. But that actually, is not the right, thinking, because, when you get to the advanced stage, that may be too late. It's kind of like going through, if you have a lot of arthritis in your knee or hip area, and if you have other medical condition, if you go to the orthopedic surgeon and they may just say, hey, it's too late for you, you're not a good candidate. So very similarly here, that if you let it get too bad, the Parkinson's disease, you may miss that window of opportunity to get it done. The next question is, also very common. Does DBS surgery slow down or cure the Parkinson disease? Slow down the progression or cure the disease. So there is a new emerging evidence that DBS surgery may potentially slow down the progression of the disease if done early stages of the disease. However, more clinical trials needs to be done to further confirm this theory, hypothesis. But DBS therapy does not cure Parkinson's disease, okay? So a lot of patients may feel, hey, this is a ultimate, procedure that's gonna take care of me. While it can take care of a lot of your symptoms, but the disease in the brain still exists, okay? You're not getting rid of the disease itself. Is this procedure covered by insurance? So answer is yes. Medicare and most private insurance companies will cover most, if not all, of the cost of the operation. So what are some complication risks? So like any surgery, there is a risk of bleeding and or infection. Additionally, there is a risk of stroke and or seizure also there, but these risks are relatively low. You can always ask the surgeon when you go see a neurosurgeon who will perform the procedure, ask them specifically, hey, what are your complication rate regarding this surgery? So, each surgeon, they may have their own complication rate. So you can certainly ask that to them. What is the recovery like? The recovery is relatively quick if there are no complications during or after the surgery. May take anywhere from 4 to 6 weeks. Patients do generally get, kind of weak after the surgery. So I usually have them go through a round of physical, occupational and speech therapy right after the procedure. But usually they bounce back up within, a month or 2 months. And, depending on the medical conditions too, if you have diabetes, heart disease, all those conditions may play a role in the recovery process. But so it varies from patient to patient. Of course, younger patients can recover faster than the elderly patients. And in my experience, recovery is also faster when you do the surgery awake rather than under general anesthesia. So what to expect after the surgery? Basically, DBS helps manage the Parkinson's symptoms alongside with medications. And it is a bridge therapy to control your symptoms. So a lot of patients may think, hey, I'm going to stop taking all the medications. The typical answer is no. You're always going to have some Parkinson medications that you will take lifelong. But about a month after the surgery, a neurologist, typically a movement specialist, will program and adjust the device settings, after a month or so, and that will help manage your, movement-related symptoms. Some patients achieve the good results within first few programming sessions, and some may take many months to achieve that. So again, everybody's different, and what we are treating is different. So you just have to be very patient in this, process. So it's kind of like going through a whole another adjustment period with your disease journey. So remember, when you were first diagnosed, you got adjusted to the diagnosis, then you start taking medication, you got adjusted to that. So this is another adjustment to, getting used to. All right. So next procedure option is the Sinemet infusion pump device called, the medication is called Duopa. It was approved by FDA in early 2015. It's a continuous infusion of carbidopa-levodopa gel. It's delivered through PEG-J tube and through the intestine where it is being absorbed. So as you can see in the picture in the bottom one, where a pump, the tube kind of goes through the stomach and into the small intestine, and outside there is a pump that infuses the medication. And the top picture is where, what the pump looks like. They made the pump a little bit big and a little bulky just because, and a little heavy, just so that way patients can handle it better. Imagine if you have a little bit of shaking, and if it's a small pump, then you can, not have a good control of it. So they made this little, pump a little, intentionally a little heavy. So how does this medication help? It can help with wearing off, reduce the severity of pre-existing dyskinesia, and who are not a candidate. So patients who have cognitive impairment, such as, if they have a lot of dementia and they're having a lot of behavioral issues and things like that, they may not be a good candidate. But let's say if I have a patient who have mild cognitive impairment or just very mild dementia and they're very stable otherwise, and they're not a good candidate for DBS, which is the brain surgery, this may be another option for them, okay? Do I have patients who've gone through DBS and this, Duopa device? The answer is yes. Very rarely it happens, but there are patients who can do both to control their symptoms. Let's look at some non-motor symptoms. So non-motor symptoms are non-movement related symptoms, and this can occur independently or can be part of your off periods, okay? And this can, sometimes, I have patients come in and they say, hey, my tremor is not bad, my slowness, stiffness, all that is well controlled, but I have a lot of problem with fatigue. I have a lot of problem with depression, anxiety. I have problems with, sleeping at night. So these are non-motor symptoms, sometimes more bothersome to the patients than the motor symptoms. And on the side, on this slide, I have listed all the non-motor symptom lists, which is, it's actually longer than this slide here, but I've listed the most common ones, okay? Let's talk about quickly the importance of exercise routine in a mid-stage of the disease. So how does exercise help? It not only improves heart, lungs, and brain health and functioning, but it also helps improve motor, non-motor symptoms, okay? It slows down the progression of Parkinson's disease, improves muscle and joint strength, tone flexibility of these muscles and joints, helps improve balance, decreases risk of falls, improves mood and overall sense of well-being, reduces depression, anxiety, and improves memory cognition. So there's just a whole lot of benefits of doing exercise routine and incorporating your daily life. So what type of exercise should you focus on? So aerobic cardiovascular exercises, if you can do about 30 minutes a day, which is walking, or if you can do jogging a little bit, or fast-paced walking, treadmill, stationary bike, elliptical. Now you can start off slowly. You can try to spread this 15 minutes in the morning, 15 minutes in the evening, okay? You don't have to kind of go all out and kill yourself with this, but you can also do some resistant light weightlifting exercise, about maybe 15 20 minutes a day, which is building your core muscle and strengthening. Stretching exercises, yoga, Pilates, balance exercises, Tai Chi, non-contact boxing. Try to make exercise routine more interesting. Sometimes if you get it to if you have it just do one or two things, you may get bored with it and you may get discouraged. So instead of that, try to do different things that may help you, okay? And let's talk about the rehabilitative services. So why do you need that? So studies have shown doing maintenance, physical, occupational speech therapies may help improve muscle strength, balance, and walking, and reduction of falls. So, it improves speech and swallowing function. So, in my clinic, I have my patients go through it at least twice a year. Medicare will at least provide that much. physical therapy and all the other types of therapies. There is a Parkinson-specific LSVT Big and Loud program you may have heard of, Power program you may have heard of, gait strengthening, balance training therapies, and neck massage therapies, okay? So these are different aspects of therapies that will be helpful for any Parkinson patients. So to the last of the presentation here, closing remarks. So, you can always continue to see your neurologist, but movement disorder specialist, we go through a specific, additional 1 or 2 year training in how to take care of Parkinson patients. So always, it's okay to seek a second opinion with the movement disorder neurologist if you're not getting, the right outcomes with your current neurologist. Now, in my practice, what I say to my patients is that, hey, it's okay, you can continue to see your general neurologist, but every now and then just check in with me, make sure your medications and therapies are optimized, okay? Don't ignore or hide your symptoms. Some patients say, hey, this is causing too much social stigma, I don't wanna bring it on, but the best thing to do is actually to, address them head on with your physician and your spouse or caregiver. Don't be afraid to take medication with fear of side effects. I have a lot of patients say, hey, I'm afraid of developing dyskinesia. I don't want to take more medications. But in reality, the not taking medication may cause you to have a poor quality of life than taking them, okay? So it can truly improve your symptoms. So don't be afraid, okay? And also don't be afraid of any procedural options either. These DBS and Duopa procedure can work well with medication to improve quality of life. Now, it's always good to get yourself knowledge and, know about the procedures before you just say, no, I don't want to do it. Always, try to explore these options, keep them on, don't keep them off the table, keep them on the table at least. And once, the ball is always in your court, you can always say, no, hey, I want to stick to medications, okay? Exercise. I can't stress this enough, along with the rehab services, and other exercise activities. This is what's going to get you much ahead in controlling the disease progression. None of these medications that we do help slow down the progression. It's the exercise and rehabilitative services, okay? So make sure you incorporate them in your routine. Finally, try to enjoy life. I know that's easier said than done, but just having Parkinson's is not a death sentence. It's not a direct threat to your life. It's a treatable condition. So I know you may see people out in the community, how bad they are, don't apply the same, what you see outside to yourself. Everybody's different. Everybody's response to medication is different. Their symptoms may be different, etc. So, just have a positive attitude about it and accept that this is the disease and, let's treat it. All right, so that's ending my presentation here. This is just a diagram I put up. It's a there's a tip of the iceberg, which is the motor symptoms, but underneath that, there is a whole host of other symptoms of non-movement related symptoms that can happen. All right, I will now give it back to Kim.
Excellent. You covered a lot of ground. Thank you, Dr. Pavasia. You also made a great transition to our next speaker. We'll welcome Dr. Jennifer Penn. She is an assistant professor in physical therapy at University of the Incarnate Word in San Antonio. She shares a passion for working with the Parkinson's community. So I will turn it over to you, Jennifer.
Hi, Dr. Penn. It looks like you're still muted right now.
All right, is the screen showing okay though?
Yep, it looks great. We can hear you just great. Thank you.
Okay, I just want to make sure. Let me just switch this over real quick, sorry. All right, so I was really excited to follow Dr. Pavasia. His words were great, and I hope that we can build on how do we get this team going. So first, I just want to tell you what we're going to talk about. So we're going to talk about why do we need a team, and then we are going to talk about who's on the team. We're going to talk about specifically more about the rehabilitation and wellness side. Then we'll talk about how to find those who really can help with Parkinson's. And then we'll finish up with talking about state laws for access versus reimbursement. So I am really excited to be here to talk to you about some of these basics of achieving the best care that we can. Across both our country and the world, there's really a growing recognition of the value and the benefit of team-based care, or what you might hear called interprofessional or multidisciplinary care, which just means we have more than just one or two doctors or team members, that we really have multiple people in the team. So I'm going to throw up a little graphic here, and I'll tell you who they are, but I think of teams in my life that I've been exposed to, maybe the A team when I was a child. They were so smart and could figure out any problem. Or if you're from the San Antonio area, maybe the Spurs team is your favorite team. Or if you're really into the Marvels, the Avengers, these are all people who together achieve great things, no matter what your framework is. And there really is growing evidence that this team-based care in Parkinson's gets the best results. This has definitely been found in Parkinson's, but it's also been found in other populations, like individuals who've had stroke or multiple sclerosis, diabetes, spinal cord injury, or even orthopedic conditions like low back pain. Truly, teamwork is what makes the dream of the best outcomes have the greatest opportunity. So let's talk about who's on the team. So not only is this interprofessional team that we're talking about important. So on this picture, Dr. Pavasia talked about the movement disorder neurologists. Sometimes there's nurses who specialize in Parkinson's, physical therapy, speech therapy, dietitians, occupational therapists, social workers, psychiatry or neuropsychologists, gastroenterologists are just a few of the people on the team. There are many more people who can be on our team. Our neuro-ophthalmologist can be on our team, a geriatrician, urologist, sleep disorders specialist. But I will say that you can have a huge team, but the most important person on this team is actually the patient, the person with Parkinson and their caregivers. Being in the center of the care and really driving the care. That is really important, because you, as a person living with Parkinson's, are the expert in your body. All of these people on the team know about Parkinson's and know about different manifestations, but you, as the person, have lived with your body the longest, and you know what things are different, what things are bothering you the most when you're not sitting in front of one of these specialists. And so you need to be an important part of this team. So for the next part of the presentation, I've been asked to really focus on the rehab part. So we'll talk about occupational therapists, we'll talk about speech language pathology, and we're going to talk about the physical therapists as well. So if you've been exposed, if you've had Parkinson's for a while, you've probably encountered some of these therapists. So I have provided kind of some of this definition of what they work on. Occupational therapy sounds kind of like what they really focus on. Occupational thinking, work or tasks. What do you need to do to be able to function in everyday life? My friends who are occupational therapists will tell you that they put the fun in functional. So a lot of activities, maybe it's getting dressed or writing out a check or making dinner or getting up and down a stool that you need to get into at home. So like domestic skills that you're thinking about that might be affected with this loss of balance, or even difficulty with things like multitasking or techniques. Sometimes there's equipment that they can bring forward that would help promote more independence, like a non-slip piece of latex that will help you open the jars easier, or mesh to help drain vegetables, just things like that that maybe you have never heard of, and they are really good at coming up with things to help so that you can do everything that you want to do in your home and at work or in the community. So physical therapy, I think about whole body motion, a lot of aerobic prescription. So depending on the nature or the severity of your condition, it may focus on things like improving your fitness level, your strength, your flexibility. We know that all of these areas, like deconditioning. So if you have problems with your balance, you probably aren't going to be as active, which means you will have deconditioning, less aerobic activity levels, which means you probably have more fatigue. Strength, if we are more sedentary, then we lose our strength for all of us, not just in the Parkinson's community. If for any reason we're less active, we get these other things. We get tightness, and then that makes it like this cyclic event where if it's harder to move, then we just don't move less. And then when we move less, everything gets even more difficult. So physical therapy tries to help in this chain and break in and address these issues. So they can even work on things like strategies to get in out of bed or out of chairs. So maybe you're not getting out of a chair or getting out of the car. Maybe you don't go out with your spouse because it's too difficult to keep up or negotiate in the environment. Those are things physical therapy can work on. Standing up and changing directions, or working on coordination, or if you're starting to feel like you have problems with dual task, like walk and talk, or you feel like your balance is just not the same, problems going up and down stairs, any of these things, any activity you want to do and you can't do, maybe because of strength or energy or coordination, all of those things you can work on in physical therapy. So there are physical therapists, occupational therapists, and speech language pathologists who specialize in Parkinson's. So that is something to be asking about when you're out looking for your care team members. The other person on the team is our speech language pathology, or also often you hear it called speech therapy. And they help with a lot of communication skills. So teach techniques that conserve energy, also work on things that nonverbal communication skills. So maybe you feel like, someone says they can't hear me and they're always telling me to speak up. That is a speech language pathologist. They can help you with that so that you can have those interactions with those that are important to you without having to feel like it's a constant battle. They can look at communication technologies that might be able to help you. If you're having problems with swallowing or choking, they can do swallowing evaluations. These are all really important for safety. Choking on your liquids, that can lead to pneumonia. So we definitely want to think about all the things that the team members can do. And the nice thing is all of these professionals really worked well together. There's areas of overlap, like speech language pathology and occupational therapists and physical therapists all can help you work on dual task activities. So there are places where you can kind of get more bang for your buck as you're going to all of these therapists together. So I'm going to take you back a little bit to what Dr. Pavasia mentioned. He had a different chart, but it's the same message of what is this passage of Parkinson's. And so, he mentioned at the beginning that before diagnosis, there's often some signs and symptoms that begin before the patient gets diagnosed. Many times these are these non-motor symptoms that he talked about, loss of smell, constipation. But there's also this thing called rigidity, which most people talk about feeling stiff. And a lot of stiffness sometimes can manifest as orthopedic pain, like low back pain and shoulder pain are very common. So then we know as these dopamine levels change, the motor symptoms increase. And that's what usually brings someone into their neurologist with these signs. We usually start with some kind of dopaminergic treatment. And then we work into maintenance, and during maintenance, we're talking about we find what works and we keep doing that. So during these phases, a lot of times we can start to see some cognitive memory issues. That dual task comes in there, maybe urinary problems, hypotension, meaning you get dizzy when you get up quickly, or pain. Again, if rigidity is not well controlled, then rigidity really can cause a lot of pain. Like I said, especially in the back and the shoulders. We see those fluctuations that he was talking about. And if we don't address them early, then we really start to get like this effect where everything is piling up together, and we get more complex situations, more falls. We see dementia and psychosis, which adds another layer to moving less. And then we really get into palliative care or hospice care. So my question for you, if you had a place to write, I would ask you, if we were in the room, so when is the right time to get a rehabilitation team on board? I'll give you a minute to think about that. When would you get them on board? Like if I were to go down the spectrum, when is the place? So commonly what we see is PT can get referred, like a rehabilitation team gets called in around here. When falls become more evident or we have specific pains, a lot of times this is when the rehab team gets called in. But what I'd like to propose to you is that there is evidence that the right time for the rehabilitation team is all along the stream. So even in before diagnosis, you're saying, well, why would I even be at rehab? So if you're having shoulder pain, if you're having problems with speech or dual task, those professionals can help early on. So when do you want this to be part of your team? I'm going to say at all parts. So before diagnosis, we know, we talked about that already a little bit. There's a lot of studies that Dr. Pavasia talked about that rehabilitation, wellness, being active is the goal. And so before even diagnosis, we find that being active and participating in aerobic exercise, which means not just going for a walk, but going for a walk at a level that you can't talk very easily. These are really important, and they can come in at any point. So if you feel like, hey, I just was diagnosed, maybe it's too early, I don't feel like I have a lot of the symptoms, even at that initial diagnosis, I would say the rehabilitation team is important because they can kind of set a baseline, see if there's anything that they can pick up. The test might be higher level. Maybe they add a lot of dual task activities and see how that affects your balance. You know, maybe your balance is just fine when you're standing there and not doing anything, but maybe when your spouse talks to you or something happens across the room and you look quickly, maybe that's when your balance is most impaired, and you may not know that until you go through some evaluation. And same thing for swallowing. So identifying these things early on helps us to get a better plan, and helps us to really keep an eye on it. So they can also maybe go over your work day and see if there's anything in the work day or at your home or in the community. Maybe it's just getting a little harder. Maybe it's carrying the plates to the table. Those are all things that a thorough evaluation will help pick up. Because maybe, you know, when we first get the diagnosis, having the diagnosis is overwhelming. There's tremor that might be present. But having the team who can maybe look from the outside can really help us get a good start. And then this idea, what does it mean to maintain with a known progressive disease? So, you know, the idea is, what is the model? You know, Dr. Pavasia talked about a great model of having patients go in twice a year. So that kind of leads me into this idea that we really need to think about what the model is. So usually in the past, and you will have to be an advocate for this, usually rehabilitation gets referred maybe once the balance is impaired, and then the person goes away from therapy for quite a while, and then maybe they have a fall, and then they get referred back to therapy. Then there's several months and something else happens. So maybe they get DBS and they're having more problems with swallowing. Then they get referred back to rehabilitation. Maybe it's years later, and then they get referred back to rehabilitation for hospice care. And this bottom line is really like saying our function gets better through rehabilitation, and then it kind of declines. And then it gets to a point that triggers the referral. They come back and they get a little bit better. And we get this downward line. And in Dr. Pavasia's slide, it was like a line upward of like accumulating problems. And we really need to change this model. This model doesn't work for rehabilitation. And I hope that you can be an advocate for it after today, that knowing that this model doesn't work for us really well, and it won't work to help us stay the best that we can be. So I'm going to offer that we change the paradigm more like what Dr. Pavasia is saying, or like a dental model. You go into the dentist every 6 months, or you're supposed to anyways, to get a checkup, and then they say, oh, there's a cavity, let's address it before it gets to be a bigger problem. This should be happening with our rehabilitation. So depending on your own disease process, it may be every 3 months, every 6 months, or every 9 months. We also have to think about what's going to get you between the bouts as well. So you need to look at the team members who are wellness professionals who are experienced with Parkinson's. So many YMCAs offer cycling classes, and some of them are Parkinson specific. Dr. Pavasia mentioned different boxing programs. There's several different kinds of Parkinson specific boxing programs. There's Pilates for Parkinson's, Tai Chi for Parkinson's, there's yoga for Parkinson's, anything that keeps you moving. So a lot of times patients will ask me, what is the best thing that I can do? And I will say the best thing you can do is whatever you will do. So I'm going to keep going real quick because I'm running out of time. So I just wanted to share, I think they're going to throw in the chat this Instagram link. You can click on it. This is a patient who has had at this point was over 10 years of diagnosis, but she continues to exercise and be participating in intense workout, and she actually is getting better. So I would encourage you to go to that link and look, because exercise really is medicine. So I have some other examples of that. This is another gentleman who does 3 times a week of kinds of exercises. He mixes his rehabilitation with wellness classes. And he had a lot of freezing of gait, and that's in the earlier video that's harder to see. But at the end, his freezing is much, much better. This is another one, the same lady you saw before. She was really active, doing a lot of ambitious things. She fell and hurt her wrist. And if you go to this link they're posting in the chat, you will be able to see the difference between one session and even a week later. It's significant how much exercise can change. So palliative care is that care that happens at home that can help when maybe we're not being as active or we can't come to the gym. So again, I'm going to leave some of this for you to read on the slides, but they will be giving you all of these slides at the end. So you need to take charge of your care. Remember, you're the expert, and you're going to ask for a team, and you're going to keep asking. So if you ask your doctor and he doesn't know, you're going to ask your neighbor, you're going to ask your friend, but please do keep up with it. I'm providing a list. So again, you're getting this handout of everyone who can help you try to find these experts and build your team. There's national organizations just like this one, the Parkinson's Foundation, the American Occupational Therapy Association. So each of the rehabilitation teams has a national organization. You can go to their website and they can help you find professionals. There's also Parkinson specific programs like Dr. Pavasia spoke of. The Parkinson's Wellness Recovery, Power for Life is their website. So again, you'll have the slide, you can look it up. They are specific to Parkinson's, and they'll have a list there of people who are trained. LSVT Loud and Big, there's their site. Interesting enough, both of these were created and designed by the same woman. The Parkinson's Voice Project, or Speak Out, is very similar to Loud. And the Bryant Grant Foundation also has these kinds of pieces of information where you can find Parkinson-specific exercise programs. The Brian Grant Foundation also does a lot of training, the trainer for YMCAs, and they're the ones who host a lot of Parkinson's cycling programs at the local YMCAs. I would ask your current team members, people who are already on your care team, who they know, who has had good outcomes and has experience with Parkinson's. You could also call local rehabilitation centers. This is a website. So again, this is more for your reference, but if you go to the American Physical Therapy Association website that I linked for you, it says something like this: choose PT, and right here in this corner, it says find a PT. Oops. And then you go in there and you put your zip code, and you can even put a specialty to say, hey, I'm looking for someone who knows neurology, and it will come up with a list. The American Speech Language Association also has a website like this, but theirs is called Find a Professional. So you have to scroll all the way to the bottom of the page to find that one. And then there's a link here to click, and it says find an SLP, which is the speech language pathologist. And then you do the same thing. You can click over here, the state and the city, and it will show you everyone who is specializing or available in your area. We're getting to the end, I apologize, but here's the last of it. Can you just walk into any clinic? So that's important to know. When you're building your team, you have autonomy, you do have some choice. So here are some things that should affect your choice. If you can just walk into a clinic is decided by two things. One is, what does the law say for those professionals? And two, what does the person who's paying for your care say? So the law will call it direct access. So that means if a person has direct access, you can walk straight into their clinic and start getting care, and you do not need a referral from a doctor. So for physical therapy in Arkansas, Oklahoma, and Texas, they all have direct access, meaning you can walk in and ask for care. For occupational therapy in Texas, they do need a referral, but in Oklahoma and Arkansas, they do not. And then speech language pathology, I did a lot of research, but what I could see was that they do not need they do need a referral. That's just the law of how you can start the treatment pattern. However, the other thing is, what does our reimbursement say? So Medicare does require a referral to pay for the evaluation. So if you want Medicare to pay or your insurance to pay, you need to check with them to see what their rules are for paying for the care. If you, let's say you already used your insurance for the year, but you still want therapy or rehabilitation, you can look for scholarships in local organizations. There are some out there. Or you can consider programs that include self-pay. So sometimes clinics or rehabilitation centers will let you pay to come and work out at the gym or their facilities, or you can again pay for wellness programs. So that's just a brief foray. You have to think about, what does the law say and what does the people who pay for this say? So those are the two things when deciding. So we went over a ton of information, remembering that you need to build a team. And the more people, like the more the depth of your team, the experts looking and helping your care really has shown to make the best outcome. There's a lot of people on the rehabilitation and wellness team, and it includes people who are not therapists who help with this wellness in between bouts. So the yoga and Pilates and boxing, but we're all working on the same goal. We talked about how to get the rehabilitation professional and the state laws. So thank you. I went through a lot of information. I wanted to thank the Parkinson's Foundation for this opportunity to talk, and for those who donated the videos today and who helped collaborate in this presentation.
Wonderful. Thank you, Dr. Penn. And now we're going to take a few minutes to practice what Dr. Pavasia and Dr. Penn have discussed regarding the importance of exercise. So everyone, we've got a Polly Caprio from Power for Parkinson's, who will be leading a short wellness break for us. It's approximately 8 minutes in length, just so you can plan accordingly. Power for Parkinson's is a nonprofit organization in the Austin area, but that serves surrounding communities and globally operates through a free YouTube video series, and they're supported by a community grant from the Parkinson's Foundation. So we'll go ahead and turn it over to Polly.
Hi, everybody. Hi, welcome to the Power for Parkinson's Wellness Break. We are going to be doing some fun exercises today that will address some of the symptoms of Parkinson's. Now, we want everybody to be as safe as possible, so make sure you have a good area where you can exercise. We will be seated for the first part and then optional standing for the second part. And if any exercise hurts or doesn't feel right, please don't do it. It's also a good idea to have a little water nearby in case you want to take a sip of water. All right, so let's begin. We're seated in our chairs and we're going to sit forward in the chair. Good posture, okay? So straight and tall. Our chests are lifted, our shoulders are down and back. And let's take a deep breath. Inhale. Exhale. One more time, a deep breath. Inhale and exhale. Now we're going to say the vowels, all right? Say them with me. A, E, I, O, let's do it again. A, E, I, O, U. One more time. A, E, I, O, U. All right, circle the shoulders up, back, and around. And let's do some wrist circles. Go the other way. All right, open your hands, close, open, close, open, close, open, close, open, close, open, close. Two more, open, close, one more, open, close. Now palms up, down, flat, pull back, 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 up, down, flat, pull back. One more, up, down, flat, pull back. Let's lift one leg. We're going to flex the foot, point, flex, point, flex, point, flex, point, flex, point. One more, flex, point, and switch, flex, point, flex, point, flex, point, flex, point, flex, point. One more, flex, point. And let's go into a little march. Again, keeping that good posture, keeping your core engaged. And let's see if we can take it out, out, in. Kind of go wide and then bring it back in. March at your own pace. And one more. And we should be warmed up. So we're going to learn 5 different exercises. And again, we're going to do them seated. The first exercise, arm swings. These help us with our gait. All right, one arm at a time. And as we do these, we're going to count to 20 by 2s. All right, so I hope you join me with this. Here we go. 2, 4, 6, 8, 10, 12, 14, 16, 18, 20. And that's our first exercise. The second exercise, slap, slap, clap, punch, punch. 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 One more, slap, slap, clap, punch, punch. All right, exercise number 3. We're going to go out, in, make it as big as you can. Keep your good posture, and we go out, in, out, in. You can go at your own pace on these, of course. And I want to challenge you, each time you go out, I'd like you to see if you can name a fruit or a vegetable. Broccoli, strawberries, carrots, potatoes. Keep going. Keep naming your fruits and vegetables as you move. Let's do one more. And nice, well done. All right, the next exercise, we're going to hold the arms out to the front. We'll do a high knee march, okay? So alternating the legs. And again, keep your abdominals strong. And we will count, okay? We're going to count 1, 2, 3, 4, 5, 6, 7, 8. Now count backward. 8, 7, 6, 5, 4, 3, 2, 1. All right, one final exercise, pulling from the warm-up. A, E, I, O, U. Again. A, E, I, O, U. One more time. A, E, I, O, U. Well done. You all did great. We're going to do this again, and I'm going to give you the option if you'd like to do it in a standing position. Keep safety in mind when you decide whether you're going to do it seated or standing, and we'll begin with the arm swings, okay? So one arm at a time, and we'll count to 20 by twos. Ready? Here we go. We have 2, 4, 6, 8, 10, 12, 14, 16, 18, 20. All right, slap, slap, clap, punch, punch, 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 slap, slap, clap, punch, punch. One more, slap, slap, clap, punch, punch. All right, the next exercise, we go out, in, out, in, out, in, out. And the added challenge, let's start naming fruits and vegetables. All right. We'll all be saying different things. Here we go. I'm going to say spinach, kale, corn, potatoes, apples, kiwi, rutabaga, kohlrabi. All right, so now we're going to hold those arms out. We're doing our high knee march. You could also have a chair in front of you if you wanted, or a counter, something you could hold on to for a little extra balance if needed. 1, 2, 3, 4, 5, 6, 7, 8, and 8, 7, 6, 5, 4, 3, 2, 1. All right, wall of water. A, E, I, O, U. Again. A, E, I, O, U. One more time. A, E, I, O, U. And let's take a deep breath. Inhale. Exhale. One more time. Inhale. Exhale. And I hope you enjoyed the Power for Parkinson's Wellness Break today. Please join us on our YouTube channel for more exercises that focus on the symptoms of Parkinson's. Thank you.
All right, thank you, Power for Parkinson's. And next we are going to welcome our final speaker prior to our Q&A panel. And we do appreciate the questions that are getting submitted. We are thrilled to have with us today Marcie Salamone. Marcie has an accomplished professional history, but following her Parkinson's diagnosis in 2017, has embraced her volunteer role in the community. She serves on the Dallas Area Parkinsonism Society and is also a Parkinson's Foundation Aware and Care Ambassador. So today she is going to highlight the importance of education regarding hospital stays. So Marcie, I will turn it over to you.
Well, thank you, Kim, and thank you for asking me to participate today. I appreciate it. As Kim mentioned, I am an Aware and Care Ambassador for the Parkinson's Foundation, and I'll explain a little more what that exactly entails as we proceed through the PowerPoint presentation. Most of us, well, at least prior to COVID-19, when we went into the hospital, we assumed it was safe. And well, many times that is true, but sometimes it may not be as safe as we think. And when I say that, I'm in no way trying to degrade hospitals or the doctors or nurses or the staff that work there. They may be great hospitals, they may be great clinicians, but sometimes people just don't know what they don't know. So when we go into the hospital, we assume as Parkinson's patients that they will call our neurologist. And well, they may call our neurologist if it has something to do with Parkinson's as to why we're in the hospital. But if we're in the hospital for a heart attack or COVID-19 or what have you, they may or may not call our neurologist. The other thing we may assume is the pharmacy will have my PD meds. And again, they may have your PD meds, they may not have your PD meds. The staff will understand PD symptoms. It's estimated that about 1 million people or so in the United States have Parkinson's disease. And while that sounds like a lot of people, and it is, I'm one of those people, so I'm in no way making light of the situation. When you look at 1 million people as compared to the whole population of the United States, well, a PD patient may come into that hospital, and some of the nurses, doctors, or staff working in the hospital, that may be the first PD patient they've seen. So they may just not know very much about the disease. And again, sometimes people just don't know what they don't know. It is in no way to degrade or the doctors, the nurses, or the hospital. They may be wonderful. They just simply don't understand Parkinson's. They will bring me my meds on time. Well, again, they may or may not. Many hospitals have kind of very set times when they bring medication. And as many people know, for Parkinson's patients, they may be taking their medicines quite frequently throughout the day, and it may not fit within that time frame that the hospital uses. And then lastly, they will know the drugs that are unsafe. Well, unless it's on your chart that you have Parkinson's disease, and unless they have looked whether something they may give you is contraindicated, they may not know that it's unsafe. So the best thing for you to do is to be your own advocate, or your caregiver be your advocate. Inpatient care of people with Parkinson's. Compared to their control cohorts, PD patients have a higher rate of hospitalization, literally 44% more than their peers without Parkinson's disease. Their hospitalizations are of a longer duration, and depending upon the study, that can be anywhere from 2 to 14 days longer. Avoidable complications are higher than for their peers without Parkinson's, and the key word there is avoidable complications. And unfortunately, those with Parkinson's are less likely to be sent home after hospitalization. On average, only 33.2% are discharged directly to their homes. 62.9% are discharged to a facility, and unfortunately, 3.9% resulted in inpatient mortality. Here you see a chart, and if you can imagine, there's 12 people lined up that all have Parkinson's disease, and 4 of them will be hospitalized this coming year. And of those 4 people, 3 won't get the right medicine on time. And of those 3 who don't get the right medicine on time, 2 will have complications as a result of that. So for 2 of every 12 people with Parkinson's, or 1 in every 6, they will have avoidable complications because the hospital doesn't understand their needs. And these are some of the issues that may occur with your medications while in a hospital. The first one is that it's missed. The medications are missed entirely by error, often because PD is not mentioned or listed in the electronic medical record if the presenting issue is not explicitly and directly related to PD. So again, you go into the hospital because you've had a heart attack or a hip replacement or what have you, and unless it is mentioned, they may not know that you even need those medications. The medication is omitted. It's withheld intentionally when a clinician incorrectly assumes that NPO, or not by mouth, indicates that PD medications should also be omitted. And severe difficulty swallowing justifies the omission of the medication. The problem is if you don't get that medication, those symptoms may become that much worse with your swallowing. So it becomes an endless circle that you can't get out of. Your medications are delayed. They're not distributed precisely at the home schedule, but rather follow the standard 1-hour window, or were set to the hospital standard distribution schedule. And I know when I was going through the training and in some of the other presentations I've made, I've heard some very sad stories of people who went into the hospital, usually not related to Parkinson's, for some other reason. and they were not given their medications on time. And it ended up causing severe difficulty for them in managing their Parkinson's disease, and caused things like hallucinations or swallowing issues. But some of the stories were heartbreaking. The last thing is that your medication can be substituted. So rather than the medication that your doctor prescribed, you are given something else. So you may be on immediate release and they're giving you continuous. You may be on a name brand, they're giving you generic. So it's not exactly what your doctor ordered, so to speak, and that may cause you some harm. But the Parkinson's Foundation, in finding out all of this information that so many people are having issues when they go into the hospital and getting their proper meds on time, tried to do something about that. And what they did was develop this Aware and Care kit. And I don't know if you can see that. I know I'm in a little box in the corner. But inside here, there's some information that you can bring with you to the hospital to make clinicians aware of your Parkinson's diagnoses. And there's 3 ways to access this information. The first one, you can go online to the Parkinson's Foundation, and you can see there, if you go parkinson.org/awareandcare, you can find the materials there. You can access all of the printable resources online for your own use, and that will not cost you anything other than to print them off at home. You can also order online or through the helpline if you wish to call instead. You can order the Aware and Care packet, which has most of the items. It doesn't have the bag. There's a magnet that you can put attached to like your hospital bed. There's a bracelet that says you have Parkinson's. The Aware and Care packet will not have those items, but it will have everything else in the kit that you need. And then in addition, you can also order the kit online. It does have an $8 shipping charge, but the kit itself is free. Or it can be distributed by Centers of Excellence or the Parkinson's Foundation staff or volunteers at no charge. If you are in the Dallas Metroplex, I am happy to hand deliver them, and we were going to put my information in the chat. You are welcome to reach out to me and send me an email or even text me, but only in the Dallas Metroplex. So I apologize if you live in San Antonio or Austin or Houston or where have you. That's a far drive. I can't go that far. Again, I am an Aware and Care ambassador, and I said I would kind of discuss what it is we're trained to do. The first thing we're trained to do is to educate the community. If people with Parkinson's know what they need, they are more likely to get appropriate care. So again, bringing this kit with you if you have to go to the hospital helps you to get that appropriate care. It lets the doctors, the nurses, and the staff in the hospital know you have Parkinson's and can get you the care you need, and they can know what it is you need when you need it. Also, our goal is to educate clinicians who treat Parkinson's. If clinicians help spread the word about resources, we can share them with more people with Parkinson's. So if you are a clinician and you are interested, please reach out again to me. I'm happy to bring a kit by that you can, show to your patients. And then the last thing is to educate hospital staff. If staff know what people with Parkinson's need and why, they are more likely to adjust the care given. And again, if you're watching and you are one of those hospital staff, I'm very happy, as anybody at the Parkinson's Foundation is as well, to talk to you and open up a dialogue regarding Parkinson's patients in the hospital. And then the Aware and Care is made possible by the Parkinson's Foundation, and you can also see the foundation there. So thank you very much. If you have any questions, I'm happy to answer them. I will be giving the whole presentation, which is much longer, this coming Friday through Tribe Wellness. It's about a 45-minute presentation, and we go into greater detail about everything, but I was trying to be succinct today. So thank you very much, and I hope that was helpful. And please, like I said, if you live within the Dallas Metroplex, I am happy to bring a kit to you if you let me know.
Thank you, Marcie. And we will include your contact information in our follow-up email as well. I think that was a great high-level introduction to it. So we're going to bring our three speakers on camera now. It's time for our question and answer panel. And I am going to go ahead and get started. My first question is for Dr. Pavasia. Can you give more detail of urinary symptoms that may be related to Parkinson's? This person's 75-year-old father has recurring UTIs, and they're wondering if that could be related. And you're on mute, Dr. Pavasia, so.
Here, can you hear me?
Mhm.
Okay, so yeah, so patients can have various urinary symptoms. In Parkinson's, they can have urgency or frequency. Urgency is basically they go quite often, or the frequencies they go quite often. Urgencies, they have a need to go right away. And they may have incontinence where they may have accidents, while whether they cannot get to the bathroom on time, or they may not even feel the bladder is full. So this can be multifactorial issue, may not all be related to Parkinson's. With getting older, it's now fun, but patients can have prostate issues. In the male patients, they may have prostate issue that can lead to urgency or even frequency sometimes, or incontinence. As we age, the bladder muscle also kind of weakens, so you may have stress incontinence as well. In female patients with multiple pregnancies and things like that, they may have prolapse bladder and things like that can happen. So there are other urological issues that may go on to develop some of the urinary symptoms. Specifically related to Parkinson's, however, can be from denervation of the bladder, where patients, the nerve that innervates the bladder, there may be dysfunction there, and that may lead to patients not feeling that they need to go to the bathroom, and then it kind of becomes a overflow incontinence. So multiple issues can happen. Typically, the way I manage it, of course, there are medication. There's medication for everything, right? But the way I treat it there, is have them see a urologist, see if there's any structural issues going on, and have them potentially take care of it. Occasionally I've had some male patients having urinary symptoms. They go see a urologist, and they even get find out that they may have a prostate cancer and such. So it's always good to get a urological evaluation from and get an opinion from them.
Okay, terrific. Our next question is for Dr. Penn. It's a good one, relevant.
Enter your meeting ID followed by pound.
And Dr. Penn, if you can hear me, and yeah, great. How do we participate in rehab services with COVID raging and everyone's social distancing? So kind of a question of the times.
It is a great question, and I was busily trying to find all the links, but there are several places. So like they mentioned, the group that did our break, they have a YouTube channel. There are some other ones. I can put them, well, if I put them in the chat, do they go to everyone?
Yeah, and we will actually follow up with some, but
Okay.
and I guess specific to rehab, is telehealth an option?
Yes, telehealth is an option in many, especially now with COVID. Medicare has made telehealth, before COVID, telehealth was not covered for rehabilitation in the outpatient setting. But now with COVID and the changes with the laws, telehealth is an option that Medicare will now pay for. And so a lot of times the other private insurance will follow whatever Medicare does. So it is good. That's one good thing that's come out of COVID, is now telehealth is more available and funded. So telehealth or other kind of rehabilitation services. And I can provide the links in the follow-up documents.
Fantastic. Thank you for that. A question for Marcie as a person living with Parkinson's. This person said, I'm finding myself pulling away from the challenges of PD instead of trying to fight it. So how can I determine what I can conquer and what is just going to be part of my life with PD? Any thoughts there?
I guess what I would say is, one, don't let it define you. You aren't PD. You're still the person you were once upon a time. You just now have some extra challenges to deal with. Still try to do things that make you happy and whatever it takes you to be your best self. So don't forget those things. Again, everyone's unique. So one person's journey with Parkinson's is not the next person's journey with Parkinson's. And don't forget that. I guess also too, sometimes I think it's easy to just attribute everything to Parkinson's disease. And I always laugh because my mother-in-law used to always say about me, the dust never settles on Marcie. And sometimes it settles now a little bit. But you know, my husband says, well, it settles on me too, because we're not 30 years old anymore. So it's just easy to just kind of blame it on Parkinson's all the time. And I don't think that's always true. And then when you find yourself pulling away, just realize that some days you're going to have bad days. But that was true before you had Parkinson's too. Every single one of us on the planet have bad days. And we did when we were 20, and we did when we were 30, and we did before Parkinson's, and we will after Parkinson's. And that's not going to, that's not going to change. So you just kind of have to look at it and say, well, tomorrow might be better. And that's how I have to deal with it. And I think probably the last thing I would suggest is find your community and find your tribe, whatever that is. And, you know, here in the Dallas area, I am the board treasurer for DAPS, which is the Dallas Area Parkinsonism Society. It's a mouthful. But, you know, they offer exercise classes and support groups and PD pals. And yes, a lot of it's hard right now because it's all online. And I know people are zoomed out. And it's not the same as one-on-one or a group in a setting, but, you know, there's those resources. Here we also, I'm an advocate for the Parkinson Voice Project. There's Loud Crowds. They're doing speech online. Tribe Wellness is the PT group I go to. He's offering classes. And then whether it's Moving Day with Parkinson's Foundation or reaching out to Parkinson's Foundation on the helpline, get yourself educated, talk to your doctors, talk to the physical therapist. As Dr. Penn said, talk to that team that you're developing and ask them, because to say it's normal, well, it may be normal for you, it may not be for the next patient. But I think the more you educate yourself and challenge yourself too, and push yourself, you'd be surprised what you can do.
I like that. And a strong message of you are never alone on this journey.
No, you're not. There's people out there. You have to seek them out though.
Yes. Okay, switching gears, Dr. Pavasia talking about with disease as symptoms of advanced chronic constipation. This person says it's not, you know, diet is not working, fruits, vegetables, psyllium husk fiber. Where do you go from there? We need to, hold on one second, Dr. Pavasia, we need to get your audio back.
Kim, we can skip to the next question for now.
Okay, we will do that. Dr. Penn, any familiarity with, we talked earlier about keeping a diary of PD symptoms that is ever so helpful with your team. Is there any online resource or any recommendation you have for something that's easy to use to do that?
To be honest, the easiest thing I've ever seen patients do is a Word document. Like, it's not fancy. You don't have to figure out any new technology. I've had a lot of patients who just do a simple like Excel spreadsheet and just, you know, it's very easy just to write it on a piece of paper. Your symptoms one way and your days of the week, or a calendar. Sometimes I'll just have my clients just grab a calendar and they can write on the calendar. So I think sometimes when I try to do like digital journaling or all those things, it just gets too hard.
Okay. Okay, great. Thank you. And do we have Dr. Pavasia back?
Yep, he's trying right now. Dr. Pavasia, you could try to unmute your phone.
I don't think that's working yet. So Danielle, I'll go ahead and go on to a different question. Oh,
Can you
there
hear
we
me
go.
now?
Yeah, we sure can.
Okay, all right. Sorry about that. We're having some technical difficulties here, but to answer your question earlier about the constipation regarding this patient who has tried multiple things, especially the diet and over-the-counter stuff. Constipation is a very common and a symptom that can present way early in the disease duration. So yes, the over-the-counter stuff is quite helpful. Miralax, Senna, Colace, those are all good options. Of course, high fiber diet, a lot of vegetables, prune juice. I don't know if you like prune juice, fruits, high fiber. So those are the big options. But if none of those things are helping you, then what I do in my clinic, usually refer them to a GI specialist. There are, a few medications that can be prescribed. One of them is called Linzess, that can do the trick. And there are other, couple more medications that the GI physician can prescribe to help you along. But drinking plenty of water throughout the day, staying hydrated also helps with constipation. Essentially, what is happening is that your GI system slows down or, comes to a halt in a lot of the severe cases of constipation, and it's hard to move with the bowel. So you have to help your, intestine along the way with all these things, over-the-counter stuff or, high fiber diet, etc. Miralax usually does the trick for a lot of my patients, so you may want to try that if you haven't tried it already. You can do it once a day until you have at least one bowel movement every day or every other day. But if none of those things are helping, then you may ask your primary care physician or a neurologist to refer you to a GI physician.
Okay, thank you. And we're going to keep you on, Dr. Pavasia, for the next question, which is,
Sure.
we had several questions about dizziness or orthostatic hypotension as a symptom and what treatment there may be.
So orthostatic hypotension, it's a big heavy term. Basically, what it means that you drop your blood pressure when you change your posture from either lying down to sitting, or sitting to standing, or lying down to standing. Sometimes it's this leads to a drop in your blood pressure because gravity takes an effect, and a lot of the blood kind of pulls to your lower extremities. And this may lead to less blood flow to the brain, and that can lead to kind of feeling lightheaded, dizzy, or sometimes patients describe it as kind of woozy feeling. It may be severe enough where patients feel near fainting spells, or they do pass out, they fall, and they can hurt themselves, etc. So orthostatic hypotension is a big symptom that needs to be treated. Otherwise, patients are at high risk for falling. So it can happen, kind of mid or advanced stage of the disease, and the way we treat it is, of course, as I was saying earlier, there's medication for everything. We do have medication that raises the blood pressure. But before we do that, we typically take away some of the medication that may lower your blood pressure. So, for example, I have so many patients who are taking blood pressure lowering medications such as lisinopril, amlodipine, beta blocker types of medications. So I reach out to either the primary care physician or cardiologist saying that, hey, here we're having symptoms of low blood pressure. Can we cut down on your blood pressure medications first and see if that will take care of the issue? Okay. And I have some patients who go off their blood pressure medications and they still have a lot of the lightheadedness, dizziness. So then in that case, I would prescribe something that may elevate the blood pressure. Some of those medication, one of them is called midodrine, second one is called Florinef, and third one is called Northera. Northera is a branded medication and it's quite helpful, but can be expensive. But midodrine and Florinef, they're both good options to raise the blood pressure. So that way, when you go from lying down to sitting to standing, you're not dropping it too low to be symptomatic.
Okay. And I do have one more for you, which
Sure.
is, we had a few questions about chronic pain and Parkinson's. Is that often tied to it, as well as, in particular, foot pain and neuropathy?
Gotcha. So pain is a very subjective symptom. That's a symptom that it's hard to manage at times, you know. So if there is a pain directly related to Parkinson, it's usually related to either dystonia. You know, the term that I described in my lecture was that constant muscle contraction that leads to stiffness, tightness, or posturing of the foot, or you know, hands or neck, etc. That can lead to you know, discomfort and pain. That's definitely, you know, related to Parkinson's, the dystonia. But you know, as we age, we also get, you know, arthritis throughout our body. You know, so chronic low back pain is by far the most common that I have most of my patients complain of. The spine, the arthritis builds up in the spine, so they may have a neck issue because of that. They have lower back pain. Sometimes this pain, this arthritis can impinge those nerves coming out of the spinal cord, and that can lead to shooting down pain into their legs. And that can cause a lot of, you know, troublesome symptoms. So pain can be, you know, all throughout the body, but as a physician, we have to rule out other causes of pain rather than just say, hey, this is all just Parkinson related. And so in my practice, I definitely, you know, ask many questions, trying to pinpoint where the pain is coming from. And if it's Parkinson related, dystonia pain, then taking, you know, higher doses of dopamine class of medication definitely helps, along with, you know, DBS can also help with the dystonia if you have a DBS implantation. So, you know, definitely help that. But if you have other pain issues, musculoskeletal arthritis, then I would suggest you know, talking to your primary care physician or pain management specialist to kind of take care of those issues.
Okay, great, thank you. And then our last question, just based on time, is going to be for Marcie. And this is from someone that says they have an aware and care kit, and they are wondering if they should keep a supply of their medications in it, in the actual bag itself.
I mean, yes, based on the training I went through, yes, that is suggested. Usually what is suggested with the kit is keep it somewhere that if you have to run out the door, you are going to see it and grab it. I keep mine in a basket that's right by the door to our garage. So if something were to happen, my husband or myself would probably my husband would end up grabbing it. So yes, there's a lot of room in the kit to include your medication in there. And you know, this also might be a great thing, for instance, if you're traveling, if you're going on vacation or whatever, and you keep the kit on you when you get on the plane, and maybe if you want to keep your medications in here, that way, if your luggage gets lost or what have you, you still have the medication. If you're, you know, you end up in Hawaii, but your luggage ends up Lord knows where, you still have this with you. So yes, I would keep your medication, some medication in here if you can, because that also helps when you do go to the hospital that you have it. Now, having said that, it doesn't mean that they will allow you to keep it and you take it on your own, but you can at least give it to them, and hopefully that's what they will give you and they know you have it. Many hospitals will not let you administer it yourself.
So that's a great tool. I've also heard, you know, definitely, I know keeping your medication list in there, keeping your advanced directive. So yeah, hopefully folks could join you for a more detailed presentation. So with that, I want to thank our expert speakers today. We sure appreciate you all sharing your time and knowledge with this audience, very large audience today. For those questions that may not have gotten answered, please do check in with our Parkinson's Foundation helpline or talk to your healthcare provider. That's important. We also, and I don't know if we have my slides pulled up here, but we want to again thank our silver sponsors of Lundbeck, Adamas, UCB, and Kyowa Kirin, and our exhibitor sponsors, Boston Scientific, AbbVie, Synovian, and Amneal. And then lastly, we have got several upcoming programs we would love to see you at again. One very exciting one on February 17th, we've got a Care Partner Town Hall where care partners are encouraged to come, engage with each other, and share caregiving tips and tools. And we'll have that moderated by one of our centers of excellence. So that'll be great. We've got Moving Day San Antonio on March 27th. That will take place virtually. And then all of our Parkinson's weekly programs for PD Health at Home. So we encourage you to check those out. For any of our Spanish-speaking audience or anyone that you may know, we've got an ever-increasing number of educational resources and programs in Spanish. And then lastly, your feedback is vital to what we do. So we do want you to stay on for a moment if you can afterwards to complete a short survey. We're also going to be emailing that out along with the resources we've talked about today and a recording of today's program, so you can go back and rewatch any of it. Again, this concludes our program. Thanks for joining us. Please take care and stay well.